I hope you all are having a good night so far. Oh, good. You can hear me. Good. um, so today's case is going to be a little bit different, but I think it's going to be fun and it's going to be really interactive. So I hope you all enjoy it. Can wait like another minute or two before we get started. Also, today's going to be lots of participation. So please, please, please feel free to like unmute yourself or type things in the chat. It'll make it a lot more fun for hopefully all of us involved. Okay, let's go ahead and get started. My name is Michaela. If you've been, let's see if it's going to sound. Yeah, so my name is Michaela. For those who have not met me before or been on one of these before with me, I am a resident at Louisiana State University, an emergency medicine resident. Yeah, that's pretty much it. Today we're going to be going over trauma, a very broad overview. And yeah, I hope you all enjoy it. Okay. So trauma is something that as emergency medicine physicians, but also as other physicians, people see a lot of, especially depending on if you live in a major urban city. And so this is something I saw during one of my years of med school. So it's basically saying like, do you think she needs a trauma center? I'm on the fence about it. And she's sort of impaled by a fence. It's a little bit dark, but it's a reality of something that we see in trauma centers. Okay, so generally we're going to go over a case. All of these other things like the physical exam, the differential diagnosis, and the assessment plan are sort of going to be interwoven in there, but I have made it so that there will be summaries throughout, so people don't feel too lost. And if at any point you have any questions, of course, like let me know. The case. So you have a 23-year, you're in the emergency department at a hospital, and you hear people like starting to make a lot of noise, and they just seem a little bit more stressed than usual. And so you hear that there's a 23-year-old male who walks into the emergency room, walks into triage at the emergency room after being dropped off by his friend at the door. The triage nurse notices that he looks pretty unwell, has a lot of blood coming from his the right upper side of his chest, and just like really isn't looking good. Because of that, there are no vitals from triage. The patient was just rushed straight back to the emergency department. There's a trauma bay there. And so this is sort of it. So you walk into the room. What do you do next? Take his vitals. Yes, take a deep breath if overwhelmed. I love that. That is so important. That's a really good one. Okay, try to ask him what happened, address the wound, ensure patent airway. Okay, so stop the bleed. Yeah, we love stop the bleed. These are all really good things to do. I forgot to say, you walk into the room with one nurse. You have one nurse who's with you. So I think that you all are like definitely on the right track. So let's see. So things that you would want to do. So just like everyone said, you want to get vitals, which is next. you want to hook this person up to a monitor, right? Like those monitors are in the hospital room, get their vitals. We want to see what their heart rate is, their blood pressure, how are they getting air and what their oxygen saturation is. If it looks like they need it, I always like to have oxygen available, like the nasal cannula or the non-rebreather that you can put on someone's face, just in case. It's always good to have that ready to go. And then this person may end up needing labs drawn, blood, liquid, something, fluids. So making sure if someone looks that sick, I would go ahead and put 2 IVs into them. So really good job, everyone. And try to ask him what happened, I think is also good. Okay. So while our nurse is starting to get the patient hooked up to the monitor, getting the IVs in, getting the oxygen set up, what do you think we should do next to evaluate the patient? Because once again, it's only you and the nurse in this room. So we talked about some things like ensuring that the patient has a patent airway. I really like that. Making sure that there's not a bleed. Is there anything else that people would like to do while we're waiting on vitals? Yep, check for consciousness. Yes, this person could not be conscious any longer. I love that. What are some other things we could do? Because someone talked about addressing the wound, but we don't really know what the wound looks like. What's something we could do to make sure we know what it's like? Yep, get his pain level. That is really important. I always want to treat someone's pain. Yep, check eyes. So you all are hitting on a lot of really important things that we do in trauma situations. There's a mnemonic for everything that you all are saying that makes it easier to remember. Okay, so in traumas, whenever a trauma patient walks in, what we do, some of you may have heard of, especially if you're like EMTs or have worked in the healthcare arena, you've heard of ABCs. In traumas within a hospital, we try to do A, B, C, D, E. Okay, so A is going to be seeing if the airways patent. Someone said that. How do we check to see if someone's airways patent or open, if they're able, if they have an airway intact? What are some ways we can see that? Listen for wheezing. Okay, good. What do you have to do if you have an airway? What's something that you can do that I'm doing right now? Speaking. Yes. So whoever said speaking, thank you so much for saying that. Exactly. You want to make sure this person can speak. So when I'm assessing an airway, the first thing I say is, hi, what's your name? If they can answer me, great. If not, then I'm a little bit more worried. And why are they not answering me? Is it because they're losing consciousness, or is it because something's wrong with their airway? The next thing to do is breathing. So someone said check the oxygen level. Someone said listen for wheezing. Yeah, exactly. Those are the things that you want to do when you're checking breath sounds. So when you're looking at breathing, what I like to do is, normally the patient's in a stretcher, I just go ahead and listen to their anterior lung sounds, but also listening for any like wheezing or anything that just doesn't really sound right is something I do. And I like to check their oxygen level. Next, C is circulation. It's easy checking pulses. Our radial pulses and our distal pulses in the feet are easy to check. Also looking for skin color. So if someone's skin is really cold or if it's really white, like that's going to be a little bit scary. And then the rest of the things, disability, making sure someone's conscious, and then E is exposure. So exposure and everything else. So you want to make sure all their clothes are off, you're going to see everything. And you want to do a good head to toe exam and then ask them about medical history. Any questions on that? Okay, so all of you wonderful future doctors just did that. So and even as for allergies and things like that, yeah, exactly. It depends on what the patient looks like. But for my more stable patients, yeah, exactly. Do you have allergies, medical history, surgical history, things like that? If they're not looking so good, then I tend to hold off on that. Okay, So this patient's airway, so the airway was patent, so the airway was open. He was able to speak in really short sentences. He was able to say his name, say that something happened to him. I don't want to give it away. Breathing. So his lungs on the left-hand side were clear to auscultation, really good breath sounds throughout. On the right side, there were decreased breath sounds. Additionally, we did some percussion, basically where you hit the chest wall, and his percussion was very hypo-resonant, so it just sounded very dull. Circulation, so the normal level of pulses we expect to feel are 2+ pulses. So if you feel your radial pulse, that's probably what you would feel. He only had 1+ pulses in all 4 extremities. Check if they need an interpreter. That is really great. So this man was an English speaking male. But yes, you should always check to see if someone needs an interpreter, because that may be why they're not speaking to you. Disability, his GCS was 14, and so we'll go over that on the next slide. And then exposure, so we cut off all of his clothes, underwear, everything, and what we saw was that he had multiple gunshot wounds. I said wounds, they were gunshot wounds, entrance and exit wounds in his left chest. I counted 4. He had 2, I saw 2 on the front side and then 2 lower down on the back side. And there was just blood in his anterior chest, the front of his chest. So anyone who works in medicine, the GCS, when we talk about seeing if someone's conscious, seeing how if they're perfusing their brain, if they're with us enough, GCS is sort of considered to be a very effective way to do that. And so when we look at this, the first thing we look at is eyes, and the score goes up to, the lowest score someone can have is a 3, the highest score is a 15. So eyes, someone who is normal, awake, doing well like us, should have their eyes open spontaneously. This guy only had his eyes open to sound, so I scored a 3 on that. Verbal, he was even though he wasn't speaking in long sentences, he was completely oriented, knew where he was, and was speaking clearly when he did speak. And then lastly, for motor, the highest number someone can get on that is a 6. Normally the way I like to ask people is, can you move your fingers and then move your toes and then do one more thing, do a thumbs up. And if they can do all of those, then they're obeying commands. And that would be a 6. And as people start to sort of decline and not get enough blood to their brains, or if they're, sometimes when people have strokes, you'll see that this number goes down, and it's important because it sort of lets us know if someone needs a tube down their throat or not. At 8, we tend to intubate someone. Okay, so really good job on all of that. So going through the rest of the physical exam, we finally have vitals. So this guy, his heart was beating really fast. So his heart was beating 135 times per minute. What do you guys think about the blood pressure? Yeah, low, yes. I like the sad face, is very low, exactly. That is not a good blood pressure. He was a younger guy, right? He was in his 20s, but a 70/30 is a little bit scary. How about his respiratory rate? What do we think about that, a respiratory rate of 30? Do you think that's fast, slow, normal? Yeah, really fast. He was huffing and puffing in there. And if someone's breathing that fast and their oxygen saturation is only 88, that's really scary to me, because if someone is sucking in oxygen that often, we would expect their oxygen rate to be a lot higher, and his wasn't. His was only 88, which was low. Okay, awesome. And then other things that we saw, so he was diaphoretic, he was super sweaty, just looked really unwell, looked a little bit pale, multiple gunshot wounds to his right chest. For cardiovascular, so he was tachycardic, which I figured would be the case from his vitals. But I could hear his heart sounds very easily. As we talked about before, he only had the 1+ pulses in all of his extremities. And then when I looked at his neck veins, they were just really flat. Like we were trying to get some access on him, get IVs on him, and sometimes we can put one in the neck, and there was like nothing there. And then pulmonary, he had the decreased breath sounds in his right lung fields. Left lung sounded great. Okay, so like, what do you guys think is going on with this patient? Do we think he's sick or not sick? That's maybe a good first step. Okay, so not sick. Okay. Okay, sick. Okay. What do other people think? There are no right or wrong answers. Yes, not having the greatest day. Yeah, so to me, when I saw this guy, he like looked sweaty. He was really pale. He was shot multiple times, and his blood pressure was low. To me, he was really sick. He looked a little bit scary. So let's do a recap because I know that we went through a lot. Okay, so this is a 23-year-old who was brought into the emergency department with blood coming from his chest after he was shot multiple times. He was able to speak in short sentences, but aside from that, really wasn't able to give us too much information. His vitals were notable for the tachycardia, so his heart was beating really fast. He was hypotensive. He had the low oxygen saturation, and he was also breathing really fast. So basically all of his vitals were abnormal. We didn't get a temperature on him. And then notable physical exam findings for your SOAP note. He had the decreased breath sounds in the right lung field, the really flat neck veins. And yeah, he just looked really unwell. So I'll leave this up for a second. If anyone has any questions in the meantime, please feel free to shout them out or put them in the chat. Okay. So a differential diagnosis for this guy. When I saw him, I was thinking maybe a few things could be going on. With him getting shot through the chest, a hemothorax or having blood in his thoracic cavity was definitely something I was thinking about. Also, I was thinking about a traumatic pneumothorax. So did he have air in his thoracic cavity? Perhaps. Something else I always think about and like to consider in someone who has multiple gunshot wounds is cardiac tamponade. Did something hit their heart, and are they sort of going downhill? And then lastly, did he have an injury of his diaphragm or somewhere else near his diaphragm, whether that be like his liver, his spleen, something that was causing him to have such a low blood pressure? Why do you all think that his blood pressure was so low? Exactly. Yeah. Blood loss, right? So that's something that we definitely have to be thinking about. Good job. Okay, so at my hospital, it's a level 1 trauma center. So we have x-rays, like portable. They sort of come over. They're like portable x-rays, but they're already in the room. So the x-ray tech was already there. And so I knew it would only take a second to get an x-ray. And even though this guy didn't look great, I was like, okay, let's just get an x-ray to see what's going on. So we don't rule out tamponade because he doesn't have descendant neck veins, right? Oh, that's a really good question. So the reason that tamponade was on my differential was mostly because he was shot. Sometimes people with tamponade have descendant neck veins, but that actually tends to be a pretty late finding. By the time they have that, it's really not good. Their heart's like very constricted, but you're right on a test question. It would be a descendant neck vein. So yeah, that's really good. Thank you for asking that question. Okay, so we get the chest x-ray, and this is what it looks like. So I'm not gonna ask anyone to read the chest x-ray, but can you tell me if this looks normal or abnormal to you? Great. Which side is abnormal? Tricky, right? Patient's right. Yeah, exactly. So remember that a chest x-ray is being shot like a camera, so coming this way, and so everything's flipped. Whenever we have an imaging, any type of imaging, x-ray, a CAT scan, everything's going to be flipped. So even though it's on our left side, it's the patient's right side, because if you like, what I always do is I turn myself next to the computer and picture myself next to the person. And so if you turn yourself to be next to this picture and you look at where the bad stuff is, it's going to be on the right side. And I still do that all of these years to my training. So imaging's hard. And yeah, so the lower right side of the patient looks a little bit weird, right? This like stuff down there. What do you guys think may be in his chest? Fluid of some sort, blood. Pleural effusion, okay. Okay. Well, I need a radiologist to read it. So the really great thing about a lot of medical training these days is that we're actually pretty good at reading basic x-rays. I'm not going to say I'm good at reading a lot of x-rays, but a chest x-ray, I can read. A foot x-ray, not so much, but a chest x-ray, most doctors feel comfortable reading on their own to a degree. If they're looking for any like breaks in the ribs or any big problems. But yes, this darkness, this consolidation down here makes me think that something like a fluid, a blood, or a something's in there that's not just air, because air is really light, or it would be dark for, on the x-ray. Okay, great job. So we're going to do a short-term assessment and plan and then a long-term assessment and plan. So the short-term assessment and plan is based off of this patient's physical exam. He's hypotensive. He like looks really sick. When I did the percussion to his chest, he was hyporesonant or dull, which makes me think that there was some type of a consolidation in there. And he was shot multiple times, right? At the end of the day, he was shot. And so he has a hemothorax and he needs a chest tube immediately. Oh, I see a question. Okay, so when we read an x-ray, abnormal right lung, yes, is the patient's orientation. So, well, so the way that we're looking at an x-ray is opposite of what the patient actually is. And so when you look at the x-ray, even though it was on the left side of your screen, that's actually the patient's right side. So I think if I'm answering your question right, it's based off of the patient's orientation, how they're sitting, because remember that it's basically like it's being shot from this way. Sorry, I'm trying to figure out the best way to explain it. It's being shot like a picture, right? Being shot at the patient. And so everything that you see is going to be flipped. So basically whatever you think, whatever's on your left side is the patient's right side. I'll say it that way. Did that answer your question? Okay, great. Okay, so this patient has like something that's really bad and that's making them really sick. And so what we need to do is put in a chest tube immediately. So I have a video. I hope it works. Okay, perfect. So I'm going to annotate, or I'm going to go ahead and say everything that's going on because they were speaking a little slowly. So the first thing that you want to do when someone has something in their thoracic cavity, whether that be air or blood or something else like an empyema, like a pus collection, is if it's pushing on the lung itself, then you have to get that out, or else the patient's not going to be breathing well and really bad things can happen. And so what we're doing here is draining all the stuff that's in there out. And so the procedure is called a thoracostomy or chest tube insertion. And the way to do it is that you want to go to the anterior axillary line. So if this is, the axilla, the underarm, right? You want to put it in at this line. So you'll go straight down, in between the fourth and the fifth is where you're going to be putting that. A really easy way, especially in men or people who don't have very large breasts, is just to look at their nipple or their areola and go straight over, just track straight over to the anterior axillary line. And that's exactly where you would put in the chest tube. Okay. So they're making an incision with a scalpel there, a little incision. They take a pair of clamps, and the goal is to get through the muscle, all the tissue, and you have to sort of like pop through it to get into that pleural cavity. And when I say like you have to put pressure in, when I'm doing this, I literally put all of my weight into it, especially if it's a bigger person, and you have to, or a really athletic person, and pop right through all of that tissue. It takes a lot more pressure than you think. They're making it look pretty easy here, but there are times where I'm literally leaning my entire body weight into the patient. And so they're popping into that pleural cavity, spreading and making sure that there's an open space to put the tube into, because the tube's not that small. It's probably about the size of like your finger. What they're doing now is making sure that they don't feel any lungs. So they're sweeping around the pleural cavity, which is a little bit bloody. They're going back in to make sure that they're in the right space. And then they're going to expand everything out because they want to make sure that there's room for the tube to be put in. So spread, spread, spread. And if someone is actively like really sick and dying, the cut that they have is pretty small. When I've had patients who really needed a tube immediately, I will make a huge cut. Now they're using a pair of clamps to put the chest tube in. And you want to point the tube towards where the problem is. So for example, if we know that this guy has a lot of blood in the base of his lungs, and so you want to point the tube down towards the base of the lungs in order to drain out all of that blood. And that's it. So that's the procedure. Does anyone have any questions on that? Okay, well, feel free to keep questions coming. So that was the short-term thing. We needed to start getting that blood out of his thoracic cavity. So for our assessment and plan, so this is a 23-year-old. He came in with multiple gunshot wounds, GSW is short for gunshot wound, to his chest. We found that he had decreased breath sounds on the right side. He had really flat neck veins, and he just was looking really, really bad with him being in the ED in the setting of having really terrible vitals. Do I use anesthesia for that? It depends. If the patient, it sort of depends. If someone is more stable, then we put them to, not to sleep, we use ketamine and basically send them to La La Land for all intents and purposes. But in someone like him, what I did was I used some lidocaine. I used lidocaine topically, or not topically, sorry. I put it into his skin and tried to also squirt some into the thoracic pleural cavity when I was doing the procedure. But for the most part, we use some form of anesthesia or something so the patient can't really feel or doesn't remember. But of course, in really emergent situations, there have been times where we don't use anesthesia, but that's not very common, and that's not something we like to do. It's literally only if it's life or death. Thank you for that question. Let's see. This guy was hypotensive, and he was saturating in the high 80s on room air. X-ray showed a hemothorax based off of in conjunction with the story. And so that was sort of our diagnosis for him. So the plan, so we immediately placed a chest tube. After we placed that chest tube, his vitals didn't really get any better. And he had 1,600 cc's, 1.6 liters come out of his chest tube immediately. I don't know if you all have ever looked at what a liter looks like in some type of a drink container or something. 1,600 liters coming out, or sorry, 1.6 liters coming out of someone's chest immediately is a lot, and it's really scary. So we knew that he was losing a lot of blood, as you all so astutely pointed out earlier. So we began transfusing blood. We finally got to have some IVs on him. And so we activated a massive transfusion protocol, and we basically just had blood coming to him. So we had red blood cells, platelets, FFP, everything. We were just transfusing anything we possibly could into him. And then we sent off some basic labs and a type and screen because we figured he'd be getting more blood when he goes to the OR. So because of how quickly he came in, we didn't consult trauma surgery. But as soon as we saw that, we made sure that they came down immediately because we knew he would have to go to the operating room. Would you stop the bleeding before the transfusion? So in the emergency department, we can't stop the bleeding because we like, as an emergency physician, unless I open up this man's chest, which is what they would do in the OR, called a thoracotomy, where they literally crack open the chest. I have no idea to see where the bleeding is coming from, like what vessels. I just have a small tube in there that's getting the blood out, but we would have to literally crack open his chest to see like exactly where the blood's coming from, which is why he needs to go to the operating room. Great question. So we were basically transfusing him to try to help him make it upstairs. It wasn't, he was losing all the blood we were putting in, if that's your question, for sure. But we were just trying to keep something like going through his body system. Great questions, everyone. Okay, so pathology. What is a hemothorax? So a hemothorax is a collection of blood in the pleural space. Who gets them? So normally we see them in people who are coming in with some type of trauma. If that's a blunt trauma, like a really bad car accident, a really bad fall from high up. But sometimes you can see them in people who have really late stage malignancies, especially lung cancers. The bleeding doesn't tend to be as massive though, or as severe as if someone came in with the trauma. Where does the bleeding, or who, yeah, and that's it, sorry. Where does the bleeding come from? So if someone comes in with like more of a low pressure mechanism, like a malignancy or cancer, it tends to come from the lung parenchyma or the lung itself. For higher pressure injuries, so gunshots, really bad car accidents, really bad falls from like 20 feet up, it actually can shear the arteries, and there are a lot of arteries in the thoracic cavity, like the pulmonary arteries, the internal mammary arteries, and the intercostals as well. And then lastly, one thing to think about is remembering that, you know, right under our lungs and our diaphragm, we have a lot of stuff. We have our abdominal area, right? And so you can have people who get a bullet can traject down to their liver or their spleen or something, hit an artery down there, and they can rupture their diaphragm and have a lot of blood from there. So sometimes you just really don't know where the bleeding's coming from, which is why, unfortunately, we're not able to stop it in the emergency department. And then why do hemothoraces matter? So hemothorax, like a massive hemothorax, sort of like what this guy had, can hold up to 40% of the total body blood volume, which is a lot. You know, once someone starts losing about 30% of their blood volume, or it's not circulating through their circulatory system, then that's a little bit scary. So being able to just have 40% of all the blood volume in just one small space in your chest wall, a little bit, or in chest cavity, is a little bit scary. Okay, so let's see. Yeah, how do I? Okay, laser pointer. There we go. Okay, so let's start off with the close-up view. So we have the intercostal muscles, which are the muscles that run in between our ribs. This is a rib here. We have the lung, which is over here. And then there are two types of pleura. There's the parietal pleura, which is on the outside, really close to the muscle, closer to the muscle. And then there's the visceral pleura, which is right on top of the lung. And what happens in either a hemothorax or a pneumothorax or anything like that is that either blood or air or whatever gets stuck in between these two pleural layers, which are called the pleural cavity. And so you can imagine, you know, if this guy had a gunshot that like its trajectory just went straight through and hit something and made a hole in his pleura, then there's really nowhere else for the blood to go except into the pleural cavity, which is pretty crazy. Okay, and so what is a massive hemothorax? So a massive hemothorax is having an initial blood loss of 1.5 liters. This guy had 1.6 liters, or a continuing blood loss of more than 200 cc's per hour for 2 to 4 hours. So like, let's say, for example, someone came in and they had like 200, they had like 500 come out originally, but then over each hour they're so losing more than 200 cc's or 200 milliliters an hour. Then that would mean that their bleeding's not stopping, and that something's actively bleeding and they need to go to the OR as well. And then this is literally what a hemothorax looks like. This is a really good diagram. And so when we put in the chest tube, like I was talking about, these ribs aren't very accurate, but let's say we put it in like here. Once you put in that chest tube, you want to point it downwards because you want to get it to where the blood is, right? If you pointed it upwards, then you would just be hitting the lung parenchyma, which isn't really useful. So pointing it downwards to where all that blood is, and that's how you get it out of there. Any questions so far? Okay. Okay, great. So diagnosis and evaluation. Okay, so I think that unlike so many other of these cases that we do during these presentations, you sort of already know maybe what's going on with the patient, right? Like you're walking in, you have vitals, you know the patient's past medical history, you have such a good picture of them, right? In comparison, maybe you looked in their chart before, in most of these cases, but with trauma patients, especially someone like this guy who just walked in off the street after getting shot, it's like, oh my goodness, like, oh, what do I do? And what you do is you try to get a holistic picture of the patient and think about going through things in a very logical and stepwise manner. That way you won't mess up. And so I always like to do is think about the injury or the mechanism the patient's presenting for. So if it's some type of a trauma and they're really sick like that, I'm going to be worried about bleeding, always. From there, once you finally get some vitals, you want to look at the vitals. Are they hypotensive, right? Like we talked about earlier, that's like a little bit scary that they may be losing blood. How fast is their heart rate? Is their heart beating really fast because they're in pain or because they're dehydrated? Or maybe it's once again because they're losing blood. And then obviously if someone has hypotension, their heart's beating fast and they look like really pale, yeah, there's a problem somewhere. And so that's normally the way I like to think about it, like sick or not sick. That would be someone with all three of those things is pretty sick. And I would be thinking about a hemothorax in them. So for imaging, especially like in a gunshot or a really bad car accident or a fall from over 20 feet. Imaging wise, how do you want to see what's going on really quickly? Because the goal is to treat this person quickly. So what we like to do is take an upright chest x-ray. A lot of times there are supine chest x-rays where people are just like laying on their backs. But for this in particular, because blood is heavy compared to air and it travels down into the thoracic cavity, you want them to be sitting up because then they will all consolidate and you can catch it like we did on that last chest x-ray. And in places that don't have the portable chest x-rays, like my facility has, with these days with ultrasounds, people have like their butterflies and everything, like it's crazy. People have all these portable ultrasounds. You can easily get an ultrasound and we'll go over what that looks like in a little bit. Okay, so here are two pictures of hemothoraces. Once again, this like wide out is bad. And if I only saw the wide out on a patient without knowing anything about them, there could be a lot of things that could cause that. But if I see this wide out in someone who had a really bad trauma, the first thing I'm going to think of is that they have blood in their pleural cavity. Versus a pneumothorax. I don't know if people were in Emma's back in February, but that looks like really bright and it's going to be like hyperpercent because there's a bunch of air trapped in there versus blood tends to be more opaque. Okay, let's see if this works. Tested it earlier, so I'm hoping it does. All right, it's taking out now. Okay. Everyone see the new screen with like the video thing up? So I'll play this video a few times again. So does anyone know what that the big thing in the middle of the screen is? What organ it is? It's on the right-hand side. It's the liver. So in ultrasound, this is the patient's liver. This bright red or this bright white stripe above the liver is going to be the diaphragm. And then if you look at this like swishy like thing up there, the thing that like looks like it's moving above the diaphragm, that's actually a hemothorax. So that like whirling motion is blood sitting in the pleural cavity, sort of just circling around. And so once again, in places, if you don't have a chest x-ray, ultrasound's a really good way to check for a hemothorax or even a pneumothorax really quickly. But for the hemothorax, you want to look really low, once again, because blood tends to settle down there. And so right above the diaphragm, you can see just blood rolling around, which is pretty crazy. Okay. Any questions so far? All right. So treatment for this patient. So you want to get a chest tube in as quickly as possible. So the thoracostomy. If the patient's hemodynamically unstable, like this patient was, you want to go ahead and start transfusing blood as soon as possible. If more than 1.5 liters or 1,500 milliliters come out at first, or if you see more than 200 milliliters over each hour over the first few hours, that patient needs to go to the operating room to determine the source of the bleed for a thoracotomy, where they basically literally crack open the chest. And then if the person's stable, once you put in the chest tube, you can go ahead and look for other injuries and make sure that everything else is okay on them, or see if they're losing blood elsewhere and you just missed a gunshot or a stab wound or another injury. Takeaways from today. So when walking into a room with trauma patients, doing ABCDEs every time will at least get you to hopefully stabilizing the patient. So you'll be able to see the important things that are wrong in the patient that could kill them, which is basically why we do it. You want to, stabilize them. It's super important to have help and delegate tasks. I feel like when I was younger, like in my training, so a few years ago, wasn't good at asking people to do things for me. I tried to do everything, but having a nurse come in, if you have a colleague, have anyone, right? When I have like shadowing med students, I'm like, shadowing undergrads, I'm like, come feel for the pulses. What do you think? So just getting help when you can. Remembering that hemothoraces, which is the plural of a hemothorax, I found out today, can hold up to 40% of the total blood volume in the body. And these patients need to receive blood so they don't bleed everything out, and also need fixation of their internal injury. You can diagnose a hemothorax with a chest x-ray or an ultrasound, and then if they're stable, look for other injuries. These are my sources. Any questions? And also feel free to like blurt them out. Sure. Let's go back to them. Oh, oops. Is there something in particular? Yes, I'll do that after I go back to the ABCDE slide. Oh, okay. So airway. So what I do, you okay? What's your name? Ask them a question. If they can talk, then their airway's intact. Because remember, the airway is going to be like the trachea, not necessarily like the lungs themselves. yes, as an emergency doctor, we do wear a lot of different hats, and that's why it's my favorite. I think it's the best specialty in the world. So airway, that's going to be intact if they can speak to you. If they can't, or you hear something like hissing out of their throat, airway's probably not intact. And then, of course, if someone seems like they're losing their airway, the reason it's important is because you'll put a tube down their throat, you would intubate them. Next, breathing, listen to their lung sounds anteriorly. Okay, anything else? Just the airway? Cool. How do you estimate blood loss? Sorry, I didn't show this part. So at the end, when we put in a chest tube, you know, the tube that we put in, that was put in that video, we don't just put it in and like let it flow to the ground. It's actually hooked up to suction. And so when it's hooked up to suction, it has measurements on it. And that's really the only way I know how much blood someone's lost. I'm terrible at estimating things. I'm like not very good spatially. So yeah, it's because it's hooked up to a suction that shows that. So let me see if I can go back to where they put in the tube. I'll like show you guys. Okay, so do you see? Oh shoot! So they had the tube in and they sort of clamped it. Again, when they had the tube in and they clamped it, they basically they clamp it because what you want to do after that is hook it up to a suction basically that has measurements there. Let me see. Let me try one more time. If not, I can see the picture out of it. Okay. Okay, so they have the tube going in, right? Okay, and they clamped it. Oh gosh, I can't pause it fast enough. But anyways, they clamp it and it gets hooked up to something. And that's, yeah, once again, how we tell how much is lost. Go to the slide before the ultrasound. Oh, do you want the slide of the x-rays? Before that one. Okay. And then let's see, what spaces are so for chest tubes, we put it in between the 4th and 5th intercostal spaces. So in between the 4th and 5th ribs, and the anterior axillary line. So the front part of the axilla go all the way down. It goes in between the 4th and the 5th spaces. Mm-hmm. Any other questions? No? Okay. Well, hopefully you all enjoyed this. I tried to make it as real as possible. So sorry if it felt a little bit intimidating, but this is sometimes what happens. How long does the tube have to stay in? Usually they get serial x-rays. So sometimes it stays in and it depends on what happens in the operating room, but they get serial x-rays. So sometimes it stays in for like a few days, sometimes it stays in for weeks. The difference between hypo and hyperresonant. So hypo is like more dull. So if you like hit like your desk or something, hit wood, it's gonna sound really dull versus if you hit something that's like has more air in it, like I don't know, like this like vitamin bottle, it like has more air in it, and so it sounds like higher pitched. Yeah. Thank you all for coming. I really hope you enjoyed it. No, hyporesonance not normal. I don't think that I would just say there's hyper and hyporesonant, and then anything in between is normal. Yeah, of course, everyone. Thank you so much.